Okay, thank you.
Thank you. Thank you very much. And we would like to shift to another important STD, which is the cancer related, which is the HPV. I think most of the time when we talk about STD, we talk about symptomatic acute STD, but actually HPV is one of the most important STI that have morbidity, mortality. So today we have an honor to invite Assistant Professor Natacha Phoolcharoen from Department of Obstetrics and Gynecology from Faculty of Medicine, Chulalongkorn University. She's the gynecologist, oncologist, but I think she's one of the person who try to prevent and then do public health approach, try to prevent before it's occur as a cervical cancer. So we will have an opportunity to learn from OB/GYN doctors about HPV prevention and also screening. Please join me to welcome Assistant Professor Natacha Phoolcharoen.
Thank you so much for your introduction and good afternoon, everyone. I will be discussing the HPV vaccines and screening in the young women. So I would like, I have no conflict of interest. I would like to start with this picture, and you may see this, I'm not sure, but for us who is gynecologic oncologists, we see this picture like many times. It's the picture to show how the cervical cancer is a burden in the world. So you may see that. So every year we have the new cases of cervical cancer, around 600,000 cases, and we lost more than 340,000 women every year from cervical cancer. And for the country that have the darker blue or red, this means like the incidence and the mortality rate is really high. So you may see that the cervical cancer burden is the majority is in the low and middle income countries like Sub-Saharan Africa, South and Southeast Asia, and also Latin America. Let's see this picture, and I think most of you may not familiar with his face, but I think you're familiar with his name. So this is Dr. Georgios Papanicolaou, who invented pap smear in the 1920s, and the pap smear's efficacy was proved by the 1941. Another doctor, this is Dr. Harald Suhausen, who got the Nobel Prize in Medicine in 2008 by his discovering the role of papillomavirus in cervical cancer in 1983. Come back to this picture again, and let's do the simple mathematics. For now, at the present, we are 80 years from the first discovery of the pap smear, and around 40 years from the discovering that the HPV is the cause of cervical cancer, and we still lost 340,000 women every year by cervical cancer. This map may feel a little bit distorted because it's just the picture that shows the disparities in mortality from the cervical cancer, that it is a preventable disease. So this picture shows the size of the country proportionally by the number of the deaths of cervical cancer. So you may see that, like we talked previously, that in Sub-Saharan Africa, South Asia, Southeast Asia, is the place where the high burden of cervical cancer and also the high mortality rate of cervical cancer. Let's see the number for the country in Sub-Saharan Africa, like Uganda, Tanzania, Malawi, Swaziland. They have the mortality rate is like 50 to 70 per 100,000 women, compared to the country with high income country like in the US. The mortality rate from cervical cancer is 2.4 per 100,000 women. So cervical cancer is one of the diseases that show the disparity for getting into the public health access. And although it is a preventable disease, but we still lost many of women every year. So it is unacceptable, isn't it? So it's not just us that think that this is unacceptable, that if we let this still continue to happen. In 2018, the WHO have the global strategy for the elimination of cervical cancer. It is the first time in the human history that we announced that the goal to eliminate the cancer. So they set a vision for a world free of cervical cancer that is a threshold of less than 4 cases of cervical cancer per 100 women. So they put a target for 2030 to reach, that is we call 90, 70, and 90. This target have 3 pillars. The first one is a vaccination. So 90% of girls should be fully vaccinated with the HPV vaccine by age 15. And the second pillar is a screening. So 70% of women get screened but with a high performance test that's supposed to be HPV testing at least twice by the age 35 and 45 years. The last one was 90%. It's 90% of women who identify with their cervical disease receive the treatment. So as we talked previously, that for now we know that the etiology of the cervical cancer is a HPV because the HPV is the cause of cervical cancer in around 99.7%. 80% of women, or like most of the women, will get infected with HPV at least once in their lifetime. But fortunately, most of the infection will resolve by itself. So this is a diagram showing the infection of the HPV. On the right-hand side is showing the normal cervical epithelium with the multiple layers of epithelium. And at the middle is when the HPV and HPV virus getting into the basal cell of the squamous epithelium. So how it can go into the basal cell is the entry is gained through the microabrasion that theoretically is always from the, it's not always, but it's like theoretically it's from the sexual intercourse. And when after the HPV get infected into the basal cell, when the basal cell get differentiation into upper part of the epithelium, the HPV virus will get replication, and when it go into the surface, that the HPV virus have more replication and can release more of the infectious particle. And in some cases, the HPV, the viral DNA replication get integrated into the host genome, and when the carcinogenesis happen, this is the case that will progress into the pre-invasive cervical disease and also the cancer. Like I talked previously, that fortunately that most of the HPV infection will clear by its own. Like if you see this picture, it's like 80% of the infection will clear in around 2 years, and around 90% will clear on its own by the immune system in around 3 years. So the natural history again of the HPV infection from the normal cell will get infected with the HPV infection, and the persistence of the HPV infection will cause the precancerous cell changes. CIN is cervical intraepithelial neoplasia, and we differentiate into phase 1, 2, and 3. We call CN1 as a low-grade lesion and CN2 and 3 as a high-grade lesion. And if you see the arrows that from normal to CN1, CN1 to CN2, and CN2 to CN3, the arrow has 2 sides. This means normally the cell can regress by its own, even though we don't give any treatment. But normally for the high-grade lesion, we will give the patient the treatment. But once the CN3 progresses into cervical cancer, the arrow has only one side, right? So it cannot regress by itself. One good thing is that for this process from persistent HPV infection into cancer, it takes quite a long time, like at least 5 to 10 years. So this is the good, maybe we can say it's a good thing of the cervical cancer, that first we can give the HPV vaccine that can like eliminate this source, and second, we can catch up the patient during the pre-invasive stage, that in this stage, if we give the treatment, the patient will can be cured. So the percent of cervical cancer worldwide that differentiate by the HPV type. For the high-risk HPV 16 and 18, together is the cause of cervical cancer at around 70%. And other HPV type, like for 31, 33, 45, 52, and 58, together combining these 7 types is combined into around 90%. So for the HPV vaccinations, the goal of the vaccination is to prevent infection with the high-risk strain of HPV. We have now available 3 types of vaccine. The first one is Cervarix or bivalent vaccine that protect against HPV type 16 and 18 that we talked in the previous slide that means it's protect around 70% of the cervical cancer. So for Gardasil or quadrivalent HPV vaccine, it is the same type like 16 and 18 and plus the low risk type 6 and 11. So this means the Gardasil or the quadrivalent vaccine protects around 70% as well of the cervical cancer. For the Gardasil 9 or nonavalent vaccine, it's covered the same types as Gardasil plus additional protection against type 31, 33, 45, 52, and 58. This means altogether protect around 90% of the cervical cancer. For the recommendation, the CDC recommends to both boys and girls in 2 doses between the age of 11 and 12 years old, but can be given as early as 9 years of age. For 3 doses of HPV vaccine should be administered if the women or boy is like at age 15 years or older. And for the normally for the at age 9 to 14, 2 doses given apart 6 to 12 months apart. And at age 15 and older, it's like the schedule is going to be 0, 2, and 6 months. For immunocompromised, the 3 doses of the HPV vaccine should be administered for women living with HIV or other immunocompromising individual. And for catch-up vaccination should be offered for females and men at age 13 to 26 who have not been previously get the vaccine. And for people who's older than 26 until age 45 should be the shared clinical decision making should be done. For 1 dose vaccine, there's many studies review and conclude that the single dose HPV vaccine offers strong protection comparable to 2 doses schedule, and the WHO Strategic Advisory Group of Experts on Immunization review this data and conclude that this should be comparable. So this recommendation is based on the concern about the slow introduction of the HPV vaccine into the immunization program and overall low population coverage of the vaccine, especially in low and middle income countries. So for now, the recommendation from the WHO is that 1 or 2 doses of schedule for girls and women aged 9 until 20, and 2 doses with 6-month interval for women older than 21. But for immunocompromised individuals, including those living with HIV, should receive 3 doses if feasible, and if not, at least 2 doses, because there's still limited data in this group of people. So for the challenges on the HPV vaccination is from the awareness and accessibility, especially in low resource setting, vaccine hesitancy and misinformation, cost and logistics of implementing widespread vaccination program. In the picture is the different colors show how the difference between each country. In some countries, they put the vaccine for the whole entire country, but for the orange one is like the place where the vaccine is still not getting into the national policy. For cervical cancer screening, so the goals of the screening is to prevent morbidity and mortality from cancer. So this prevention works via identification and destruction of the true cancer precursor. It's not that the goal is not that to find the lesion or not to find the positive test, but the goal is to find the true cancer precursor. So for molecular diagnostic test that now that we have and we use a lot is the HPV DNA testing. The test is to detect high-risk HPV type. It is highly sensitive for identifying women at risk of cervical cancer. Other kind of molecular tests are HPV genotyping. It's like to test specifically what is the type that is positive. So this one will identify specific HPV types and useful for monitoring high-risk population. And in our country, we don't use it that much, but like in some countries, like in the Europe, or where they have a high coverage of the cervical the vaccination. Now they are trying to see how the trend going on after most of the people in the country get vaccines. So the last one is the HPV mRNA testing, because they focuses on HPV E6 and E7 oncogene expression, indicates active infection that more likely to progress to cancer. So briefly about the recommendation on the screening, this one is the United States Preventive Service Task Force. So they recommend to start at age 21 and 21 to 29 years old. Recommend to test with cytology alone every 3 years. And after that can be every 3 years with cytology or every 5 years with high-risk HPV testing. For American Cancer Society, after they reviewed that they have a really low incidence of the cervical cancer in people younger than 75, so now they recommend to start screening at age 25 with primary HPV testing every 5 years is a preferred method. But if the primary HPV testing is not available, should be screened with the co-testing, that means combined between HPV and cytology or cytology alone every 3 years. For women living with HIV and immunocompromising condition, the recommendation is to start within 1 year of onset of sexual intercourse and no later than age 21 years, and should occur at the time of HIV diagnosis in those age at least 21 years. For age less than 30 years, recommend to screen with annual cytology until 3 consecutive normal tests, and followed by continuing testing at 3 years interval. For the age 30 years or older, recommend for co-testing at 3 years interval or annual cervical cytology until 3 consecutive normal tests. For emerging techniques, for now that we have some emerging and new techniques, the first one is self-sampling HPV testing. Is the way that the women put the device into their vagina and send the sample to test for the HPV. This has proved in many of the studies that it can increase the participation, especially in the under-screened women. Other kind of testing is the point-of-care testing, that is like the portable HPV testing device for remote or resource-limited setting, but it is still in the study. And lastly is the artificial intelligence that they try to enhance accuracy and efficacy in cytology and colposcopy. So for challenges and consideration for the screening is that the transient HPV infection in young population, in the young people will have a high prevalence of HPV, but the low progression to cancer. So we will try to avoid unnecessary biopsy and treatment in this group. For the cost and access to molecular tests, the HPV testing may be more expensive than cytology in many countries, and we will need for affordable and accessible screening tools. For psychological factors, because fear and stigma surrounding HPV and is linked to sexual health, and it is important for counseling and education before and during screening. For self-sampling, we still have barrier on the acceptance and proper technique among young population, and we need to ensuring the follow-up after positive results. So this is a summary of the recommendation for young people, and as I talked previously, for vaccine and also for screening. So for the best practice for young people, HPV vaccination, screening programs, and moreover, one of the very important is the awareness and education, because education about HPV, about cervical cancer, vaccination and screening is essential for empowering young people to take preventive actions. And school, university, and hospital should be a good place for educational campaign and put education for the people. So together with vaccination, screening, and also education, we hope that we will move closer to eliminating cervical cancer, and hopefully we will reach the goal in the near future. Thank you so much for your attention.
Thank you very much, Dr. Natacha, for a very compelling talk about the need for screening and management of cervical cancer in young women living with HIV. We have 5 minutes for questions. Does anybody have any comments on if you provide HPV vaccination in your countries, or if you have any challenges with the screening and management of HPV? Yes.
Okay, thank you very much พี่นัทขอบคุณอาจารย์มากครับ thank you very much a Korean neurologist at the Department of Preventive Social Medicine Chulalongkorn University. From the experience in the HPV clinic and even in our department, general populations, asking people to do cervical screening is quite a big challenge. Even Ajahn and me work in the same hospital, but for the checkup program, we have to put in the appointment consultation to the gynecologist, which of course might not be too appealing for a lot of patients. So I was very interested in the self-collection, and if my understanding is correct, at least in Thailand, the NHSO has picked up the self-collection sampling through the applications. So my question is twofold. The first thing is, as a healthcare provider, how much confidence in terms of the performance sense back of the self-collection, and secondly, more kind of like the public health impact. On your opinion, like how well have we been doing in terms of increasing the uptake of cervical screening using the self-collection?
Thank you so much. So for the first part, it's like for the efficacy, like sensitivity to screen. So I have done some of the study in Thailand. So but it's a small study. So one thing is that when we do in the study, like the people who's really small group, and when we give them and tell them closely like how to do it, the result is really good. It's like comparable to the physician collected. One thing is that because HPV is not just confined at the cervix, it's still in the vagina. So this means the HPV should be comparable between the, it's not the same as what comparable between in the vagina and the cervix. But one thing that we find, I mean, it's not official yet, but from the NHSO and like NCI in Thailand, they said that they got many kind of like inconclusive or some kind of like the result that is not as good as from the study. So I think it's maybe important that in Thailand we need to have like more data for the real population, because from the meta-analysis or almost everyone is also always good. And for the way to increase participant is, I mean, in Europe, it's like most of the study is good. It's like can increase the participant, but there's doing many kind of study. Like for example, in some study they do like send to all. They found that sending the device to everyone is better than like to opt in, like for the study. But the thing is, in Thailand, I think it's maybe not easy to send the device to everyone, and we will lose lots of money, lots of device on that. So I think it's still in the process that we need to work on that. Thank you.
Thank you so much, Ajahn Natacha. So we're just coming up to the break time now. So we have a few notices. You might have seen just before we started that there is a event that's coming up on the February the 13th. The Children's Hospital of Philadelphia, in collaboration with Chulalongkorn University, are holding. a case conference in contraceptive youth and adolescents. If you're interested in joining, feel free to add this on the registration QR code. This series of events is also going to continue this year in April for mental health care in adolescents, and also in June there'll be an event on gender affirming care. If you want to ask any more questions on this, feel free to come to me or Dr. Tanyawi during the break. The next thing I wanted to mention was considering joining the Penta ID network, and Professor Gareth will tell us more about that.
Thank you very much, Nat. Just very briefly, I just wanted to plug this, that the Penta ID network is very much an international global organization involved in infectious disease research in children, young people, and also pregnant people. And we are very keen to get the word out because we are moving way beyond HIV, lots of other investigations in MDR, in AMR, and other territories that may be of interest in the region. And particularly for early career researchers, we have a very active program of both mentorship and support to try and get your research ideas paired up with people who can really make them happen. Thank you. So if you can use that QR code, applying is a very straightforward process, and we will welcome your applications and then also connect you with people within the region, hopefully. And if I can have the next slide. This is just a very quick plug for those of you who have clinical cases, particularly challenging questions around optimal antiretroviral use in HIV-infected youth and adolescents, and again in pregnancy. There's a virtual clinic that is run by Dr. Caroline Foster with colleagues at my unit in St Mary's Hospital in London, and every month it meets at a time that is actually quite easy for Southeast Asia. And if you email Caroline, she will be very happy to add your cases, and it's a really informed discussion that involves people with tremendous amount of experience all over the world, including Latin America and Sub-Saharan Africa. Thank you very much.
Thanks, Gareth. And the last notice we have is for anybody who is interested in applying to APAC, which will be held in Tokyo this year. Abstract submission is now open. If you have any other questions, you can go to the website or also come and speak to me during the break. And it gives me great pleasure to introduce to you next a performance. You'll see at the back of the room there are many young people getting ready to produced a very lovely performance for us named I Am Me, LGBTQ Youth. And really we put this performance together by these young people to empower them and give them a space to express their needs and their viewpoint of living as LGBTQ people. So this performance is youth from the youth cab at the CU Buddy Clinic at Chulalongkorn University, and the students from the Faculty of Fine and Applied Arts at Chulalongkorn University. So welcome, and we hope you enjoy the performance. After this performance, we'll be taking a break, and we'll be back at 3:15. Thank you.
Peaceful, not good. Confident. Enjoy. Peaceful. You not do it. Enjoy. Respect. Peaceful. Enjoy.